Welcome to IPCI, by the way.
Yeah.
And then
Morning.
Good morning.
Yes. So can you hear me and see me?
Very clearly.
Okay. So can we have the case? It's a very interesting case. So this is a 63-year-old lady who is diabetic, hypertensive, had an inferior wall MI thrombolized outside with streptokinase, had a mild LV dysfunction, EF about 50%, a syntax score of 9, had an angiogram done about a week ago, and that's the LAD, which you can see. We'll show you some better pictures today. There's about a 40-50% lesion in that mid LAD. And then you go to the right, and you can see in the right that there is a lesion in the mid segment and in the distal RCA and PDA. So there are tandem lesions in the right, and if you can show today's pictures again. So we've given some nitroglycerine and show the first 3 shots. The left coronary, please. Okay, so we can see today's next view, please. And there is that mid LAD lesion after nitroglycerine, doesn't look too significant. And the right, you can see clearly 3 lesions, one calcified in the mid segment, distal RCA, significant stenosis, and a PDA. So what do you think we should do? So maybe we'll have the questions of the house and then show what we are trying to do here.
Well, I think that's a great case, a delight for imaging, but not a great delight for intervention. I wish we could only do imaging on this and nothing more than that. Because it's delight because you have these borderline lesions and we don't want to know their physiology and their effect on the myocardium, producing ischemia. And then there you have all this calcification. Would be delight to see on imaging modalities, but intervention is not going to be a piece of cake. So,
Okay.
Panel, I would actually ask the panel as to what would they want to do with this. So, could we have your comments on this, please?
Imaging and
Okay.
imaging followed by maybe a rotablator if we find significant calcium for the mid RCA. The distal RCA and PDA probably just balloon dilatation in case you find significant lesion, and then the stenting strategy could be starting from the PDA to distal RCA, jail the PLB, and then stent the mid RCA.
Okay, how many would do a functional test? Because we don't know, the inferior wall MI has happened. We don't know really what's the culprit, what's not the culprit. And would be anybody's guess as to would you do a functional testing on this?
And here's the situation again of my asking anybody from the, okay. What?
I think Dr. Ajit, by seeing the multiple lesions here, the physiology definitely will be positive by looking at this angiogram. So imaging will give a clue whether to intervene, how to intervene and all. But physiology actually to look for the lesion significant, whether it is significant disease or not. I think there is no much of a doubt about looking at the angiogram. It is significant.
So here's the situation. I think I'm sure somebody in the audience may actually ask you whether the mid lesion is significant or not. The distal lesion certainly looks significant, and if the patients had inferior MI, hopefully that is the culprit. Maybe if you were going to push the option for measuring physiology, then it would be only after treating the distal lesion to decide on the mid lesion. Otherwise, I don't think we would have any idea about any discussion on the distal lesion from. I don't think anybody in the audience raising hands for distal lesions.
The mid RCA lesion is likely to be more significant than what it looks to the eyes, because calcium will always tend to underestimate the lesion, because calcium is also producing a shadow.
Correct.
And the contrast is also producing a
And
shadow.
so the imaging and so physiology would become relevant after treating the distal lesion.
Okay, so
for the mid lesion.
Ashok, what I'm going to show you is what IFR gives, what FFR does not. And
That'd be
we
very
have an IFR with a co-registration. So I'll show you how we do this. So can we just show you how we do the IFR? So there is the errata wire of show the angiogram, please. So the first thing that you do is basically just like FFR, get the wire down and you basically normalize it. So you put the transducer there, normalize it, and I could the IFR wire is pretty okay. It's a good wire to go through.
Yeah, how
And
does
you
it
could-
travel down these calcified and tortuous arteries?
Yeah.
Does it
So I'll just show you. I took a small fluid of that. So can I just show the next shot, sitting? So you can see that the IFR wire, with some difficulty, does navigate through all this calcium, and we could park the IFR wire really distal to both the proximal lesion and the distal lesion. But clearly there's calcium and difficulty in getting the wire down. Okay, now Sayan is with me, Sayan Sen is with me, and he will tell you what we found on the IFR. Very interesting.
Thank
Sayan,
you.
can you come in?
Thank you, Ajit. So a really good case. I was interested to hear the panel's thoughts on the physiology side of things. One of the comments was we can only really assess the mid-vessel once we've treated the distal vessel. And that's true, of course, if you're requiring a hyperemic index, but IFR is able to allow you to differentiate between the distal and the mid-vessel prior to any intervention. So if we just go through some of the hemodynamic measurements that we've made, the first IFR assessment point for it was extremely positive, as you can see there, 0.48. No debate with regards to the significance of that. We also did one with some contrast, I believe, Ajit?
Yeah.
And that was 0.45. So very, very significant. The question is this coming from the mid-vessel, the distal vessel, or a combination of both? At this point, what you can do is a pullback. So I don't know, Ajit, if you want to talk them through how to do a pullback.
So if you can see this pullback, and Sayan, can you just explain this whole picture? And this is a very interesting picture.
So what we've got here is the wire in the distal vessel, and this is the proximal vessel, and this is an IFR at each point coming up the vessel. Each of these marks here is an IFR at each point in the vessel. You can see here the raw pressure traces. If there is an error or some question mark that the software detects about your pressure trace, it will mark it as an X but allow you to continue to do the pullback. If we take a look closer at that error, you can see here, as we're pulling the wire back through the distal vessel, there's a bit of whipping artifact. You get a systolic jump as the pressure wire is hitting the side of the wall. Once we get out of that tortuous segment, it then goes back to your normal trace. If we take a larger view, you can see that there is one step here and a much larger step just at the level of the bifurcation here, and this is the rest of the vessel. The question is, can we accurately map this hemodynamic data onto an angiogram? I think that's our next step.
So basically, the distal lesion in the PDA has a small jump of about 13, and then you have a big jump at the bifurcation, and the major bifurcation, the major jump is that you can see the dots now. Can you see the dots? The dots suggest the severity of the gradients. So if you look at the real gradients, if you look at the distal lesion in the PDA, in the bifurcation, which is huge, it's about 38, and really in the proximal or the mid segment where we thought was the lesion, it's just one dot, and it's not very significant. So critically, the significant lesion is the distal bifurcation, and the second critical lesion is the PDA, and the proximal part is mild. So this is what physiology teaches you, though and the length of the lesion is about, say, 36, 37 millimeters. So I think this is what. Is there any discussion or doubts on this? And this can be beautifully done by a co-registration of IFR.
Yeah, I like the co-registration of IFR. So what you're saying is that the mid RCA lesion did not show any differential gradient at that point.
That's correct.
Okay.
Just one, very minimum.
Right.
Okay. So then we thought that we obviously that RCA has a significant lesion anatomically at the mid RCA and there is calcium. So we need to IVUS this whole thing to check whether how we are going to get all the catheters and stents down that, because we may need to modify, though the physiology is not significant, to get the stents and balloons down. So as expected, the balloon, 2 millimeter balloon, had difficulty in going down and we pre-dilated. Can I show the pre-dilatation, please?
So would you actually say that this is one of the advantages of IFR over FFR in the fact that you don't need to do away with lesions interacting with each other and therefore are able to get physiology at multiple points without bothering about interactions and pre-treatment, etc.?
Yeah, I think this is critically the most important advantage that IFR today gives. Otherwise, with FFR, you need to fix the tight lesion first and then look at it again. But IFR is independent of this, and clearly that's the lesson which IFR teaches us. So we know that now, which is the lesion creating the problem. Okay, so
what have
we
you
did,
done?
yeah. So what I did next was it was difficult to get the IVUS catheter, is the Polaris catheters down. So we have pre-dilated. We had to pre-dilate the mid RCA and the distal RCA. And can I see, so you can see that, and I'm trying to get an IVUS picture to know what to do for the proximal bit before we decide how to go. So now we'll show you the IVUS. We have a pullback IVUS after dilatation with a 2 millimeter balloon, and you can see from the distal sign. You can go ahead and read that for me, please.
Yeah, sure. So we're in the distal vessel here. It's probably a 3 millimeter vessel. Probably wouldn't get more than a 225 in there. Gets very tight, just proximal to the bifurcation. Eccentric plaque there going from about 12 to 7 o'clock. And here we go, just passing the bifurcation. Very tight, proximal to the bifurcation. Now into the main right coronary artery, distal right coronary artery there. Large vessel, 4O, media to media. Probably be okay with a post-dilating up with a 3.5. Again, calcific disease. We're not quite into the mid-vessel yet. Bit more calcium there at around about 12 to 2 o'clock. It's quite a large vessel, even in its distal aspect.
That's a 4 millimeter.
Yeah, absolutely.
Yeah.
Media to media.
Media to media, 4 millimeter, absolutely. So there's a bit of a size disparity between the PDA and the RCA, and we're just about to arrive now at the mid vessel, where all the action is. Again, fibrocalcific disease there. We've prepared this, so you will see some cracks within the calcium. Non-compliant balloon's gone up, but very calcific, as you would have expected on the.
That's
on the
circumferential calcification.
Absolutely, but I think you can see some cracks in there from the non-compliant balloon inflation, so I don't think we need to probably prepare this anymore. I think a stent would expand quite nicely in that. I don't know what you think, Ajit.
Okay, so we've got some more information. The distal diameter, if you could tell us.
So this is coming across as probably I would say a 275. I'd probably take a 225 as we agreed.
Yes, it's about 2.5.
Yeah.
I think distally.
Yeah,
it
absolutely.
did grow a bit after the ballooning. And can we just look at the bifurcation?
So that's
where
the
what
bifurcation there, I think. And we're coming a bit proximal to the bifurcation.
The bifurcation's calcified as well.
Yes.
Yeah, absolutely.
So did you manage to, I mean, that's really impressive that the catheter went across the tortuosities and calcification right to the PDA, should we say.
Yeah.
Do you find that this catheter is any different to the
Yeah, I
Boston
think
Scientific?
both. Yeah, I think both the IFR wire and the Polaris catheter are much better than their previous, their generation. They're
Yeah.
much more tracker. And so what I'm doing is I'm just getting another wire down, just like a buddy, just to help me to track everything down now. And small check down.
Right.
So I expect difficulty in tracking a few things down. I'm going to put this down the PLV so that I have a buddy support. And what I'm
Ajit,
going to do is, yes,
I'm going to actually ask you a question,
yes,
which is important and I think very relevant. You see, while we're demonstrating great stuff on imaging,
yes,
we also have to put it to the perspective of daily clinical practice without everybody believing that these cases can only be done with imaging or without imaging. And in reality, all of us who are image conscious, even in the best of the centers, only image 25% of our patients. So in this patient, supposing this was not a live demo, supposing it's great demonstration of an understanding, and which is what we are here for. So discounting that, would you still image such a patient, or would you just go and stent the distal lesion based on your angiographic sizing rather than try to get an IVUS catheter into that distal PDA to get some information about sizing?
I think, Ashok, I would have IVUS this anyway in my practice because of a few things. One is there was difficulty in tracking these wires and balloons even down that mid. And two, I still expect problems when I track. I just want to be sure what is the calcium extent. There is certain areas we have cracked the 360-degree calcium with the 2.5 balloon, but I'm not still happy to leave there and get the stent down now yet. I would possibly sculpt this again and just sculpt it and have opening which is wide enough for all the stents to go down. So I think that an IVUS helped me for a few things. One is the diameters distal, the diameters at the junction, the diameters at the proximal, which we clearly saw was 3.54, and also the calcium extent. Without this, you could have possibly rotablated, but the distal PDA is difficult to get there, and that was tight too. The bifurcation was tight. So, and getting a rotablator right down there would be a little tight. Maybe the proximal part would be rotablated. So I think IVUS would be mandatory. If I had that. If you don't have it, well, we still could go ahead, balloon dilate, do a angiosculpt and fix it.
But Dr. Ajit, I have a different doubt. Actually, with this calcium in the mid RCA,
Yes.
what is the chance that you can take a stent down without doing
Wow.
anything in the mid RCA? I don't know. I have by seeing this.
Okay, so I'm not sure yet, but what I'm doing is I've got a buddy wire, and now I'm going to get an angiosculpt and get that there. If it goes through, then I'm lucky.
Is it a regular wire or is it a Grand Slam?
Yeah.
Sorry, I couldn't hear yet.
Is it a support wire like
well-
Grand Slam or All Star, or is it
Well, I have right
workhorse
now
wire?
a
like a
BMW and Sion, but if
Yeah.
I find difficulty, I may shift to an extra support wire. Yeah.
Yeah, I think for the people around, it's a very useful point that has been raised. If you get these extra support wires down,
So actually, in my practice, if I don't do imaging, I will just take a Grand Slam wire along with that, make the straightening of the RCA in the mid part, number one. If it is not possible, I try to take a guideline or a guidezilla inside to the mid distal RCA, then only I take the stent if I don't do a rotablate.
Okay.
Otherwise,
So we've got the angiosculpt there, and we're going to go up there. Go up.
so
to-
here's a
So,
very relevant strategy. So what are the other strategies around this?
I have a question. Can I ask?
Yes.
Dr. Ajit, this buddy wire sitting there, will it not interfere with the angiosculpt
Not usually.
cutting
Not
all
usually.
the edges? Because one of the sides, the guide
Yeah.
wire will come between your cutting edge and the...
Yeah, I agree, but I hope not.
And
Yes,
no,
Doctor.
you can also argue that the wire could act as an angiosculpt. The body wire
Yeah.
could act as an
Go
angiosculpt.
up again.
I exactly had the same question because I thought the company Angiosculpt does not recommend another wire because I have asked them this question. But do you all use this on a
Deflate.
regular basis or what is
There's
it?
absolutely no contraindication to using it, but not absolutely
check.
not with a flexotome. But there's no contraindication to using this. It hasn't got sharp blades, and that's the specific reason for it. They believe that the efficacy can go
Go up.
down.
10,
But
12,
with
14,
a
16.
non-compliant balloon on the side, I mean, if this is, as you know, it's not it's a high pressure,
10,
it takes
12,
high pressures,
14.
but it expands also.
Deflate.
So that's the only reason why they recommend it. But there's no big deal, there's nothing wrong with doing it.
Go
I
up
was actually
again.
just going to state that this was a very important point, that if the IFR was negative, and therefore one wanted to
Deflate.
avoid doing anything and yet
Inflate.
get the distal lesion treated, it would be very reasonable to put down a guide liner so that your devices could go beyond the mid lesion,
Yeah.
which anyway did not require intervention based on IFR.
We already dilated that segment with it.
No, I'm saying it was dilated because of the inability to get equipment down. And therefore the point is relevant that if
That too, the dilatation was done with a 2
Small.
millimeter balloon, which is definitely not-
2.5. But I would then, once we have dilated it, it then seems reasonable to go the full way rather than dilate a lesion just to get devices down and then not do anything about it.
Okay, so
Dilate, you have
we've
committed
done some
yourself to stent
angiosculpt.
lesion in the end.
Yeah, just take a shot, please.
So Ajit, where are you now?
Yes, so I've done an angiosculpt 2.5,
Yeah.
and this is what we have. And what I'm going to do now.
And just sculpt where?
Yeah,
Where did you
right
do that?
with the mid segment.
Where-
Oh,
the
no.
mid segment.
Yeah, so all through the mid segment.
So Ajit, I'm concerned that, and again, maybe I'm not understanding this, but this vessel mid is large. There's no question about it. We actually think that it's 3.5. It should
Yeah.
be really, and we still pretty much not preparing it properly.
Yeah.
We sort of half-hearted in preparation. I mean, if we go to get devices down, there's no point. We could actually take a 3 non-compliant, go up to 20 atmospheres, 20,
Yeah.
25
So-
atmospheres.
So this is
After
what I'm
all-
going to do next.
After
So-
all, we got to do a good job on the proximal as well as
Yeah.
the distal.
So this is what I'm going to do next. We're going to get a 3O balloon. So I did it sequentially, 2.5 non-compliant, 2.5 angiosculpt, and now a 3O. Prep the whole area down, and then see how the balloon moves up and down, and then only even open the stent, because I'm not in a hurry to put a stent before we prep it. Yeah. So 3O balloon, please. Yeah. Yeah.
Okay. So what's the sizing of the distal lesion,
Yeah,
should we say?
it's 2.5 distally and 2.75 just proximal to the bifurcation,
Okay.
approximately. Yeah.
So while you're preparing on this,
Yeah. You can go back to Matthew
That's
and
right.
then get back. Yeah.
absolutely. And then we'll see you once you've implanted the stent distally and decide what to do proximally. So can we then go to the Apollo lab with Dr. Matthew?
Sure.
So Ajit,
Yep.
yes, what do you have
Okay.
to say? We'll
Okay.
come to
So
you.
let's just go back to all the shots. Yeah.
Because we may be running out of time, and that's why
Yeah.
I want
Just go back to all the shots.
Dr. Ajit to say.
Yeah.
Yeah, go ahead, Ajit.
Yeah, so what we did, can we show back all the back pictures? So what we did was we passed 2 wires, we post-dilated with a 3O balloon, and we got a 2.5 38 synergy. So go show that, please. So that's the synergy, just run it. You can see the synergy tracking down nicely there, and then we pull back the second wire in the PLV next shot. We pulled it back, positioned this whole thing. We are pretty happy with that. Dilated the stent, and post-dilated with a 2.5 through the stent and a 3.00 proximal to the stent. And show the other previous picture. So we've got a distal vessel pretty good, and we're now tracking 3.5 38 synergy again. Okay. Let me go back to the other view. So it's a bit tough to get stents through, but I think we are reasonable. Small check. Okay. I took a little generous length, Srini.
I thought it was too generous.
Maybe. Okay, so we go
Anyway.
up there. Yeah. Yeah.
That's
Go up.
right.
1 minute. Just get
That's
the wire
right.
back.
You might as well
Yeah. Go up.
give him a good value for his money.
Yeah. 2, 4, 5, 6, 7, 8, 9, 10, 11, 12. Hold it there for a minute. And each time you do this, you pull your wire back so that the wire doesn't get trapped.
So tell us more about that nice oval highlight picture that I see on your screen.
Okay, that's you can get a dynamic balloon dilatation in the Phillips. So we don't need to do cine. We can see it on fluoro. So you can really see the balloon is nicely opened up. Yeah.
That's called angio plus.
It's angio
They
plus.
have- Whatever you get in this thing,
Go up
stent
once
boost,
more.
you get with the fluoroscopy.
You get with fluoroscopy
Yeah.
without taking a cine.
So you don't need to cine, yeah. Okay, so we are just going up and then deflate. So I think we should be okay now. And just pull the guiding back so that,
So it did the guiding dive in.
yeah, it did, yeah. So I'm just back. It give me a 3.5, 8
So that
Eight.
was 3.5, very
Yeah.
nicely deployed at 12 atmospheres,
Yeah.
which is the right thing to do. You don't want edge dissections. You don't want. Kirti just stood up. So Kirti,
Just these calcified lesions.
Kirti hits hard in very soft words. So Kirti, go ahead.
No,
You just-
Ajit is a great operator, and I
I
love
told
the
you
way he
soft
handles
words. They
this.
start off with soft words. Go ahead, Kirti.
No, I have I'm at a crossroad to think that we started off doing an IFR, and in this tandem calcified lesion, which was obvious on the fluoroscopy, my assessment was that we are going to have difficulty with the amount of calcium. And having said that, our IFR led us to believe that the mid-RCA lesion maybe doesn't need to be touched. Now, if we didn't have IFR, I would have thought that you tackle one of them, take the proximal one in a calcified lesion, always the proximal one first so that you can reach the distal one. If the IVUS wasn't going or if the IVUS couldn't track, probably use a rotablator. So tell me, how do you put this into perspective? Because now for the fellows, they think that the IFR showed that the proximal mid-segment was not significant and you ended up putting a 38 millimeter stent.
yeah, well,
So,
I
how
think
does this pan out? I mean, I want you, Ashok, to put this into perspective so that we don't go back with this impression and come back to the view that we need to look at the patient and not at the value.
Perfect. I think, Kirti, like I said, I really, you exemplified what I was saying.
Well-
You absolutely so correct. And I want Ajit to answer that, and then we could give our
So
perspective.
let me. So Ashok, thank you very much. So let me put it this way: if suppose this did not have the calcium or the tortuosity, what we saw, I wouldn't have touched that mid-RCA. I would have just left it alone. Yeah, but now because the problem is I can't get the distal stent without fixing the proximal area. So really the stent was to provide a path, unfortunately in this patient, though on hemodynamics you don't need to do it. But if this was a straight right, I would not have done anything, you know, I would have just left it alone.
Okay, so we have time, and I think I should give my perspective.
Yeah, 20.
I think you raised a very valid point. I raised it earlier that we've used imaging, it's shown us a lot of good things. But really, how would we actually handle this patient where an IFR shows us that the mid lesion should not be done? And of course, it's a very unfavorable lesion. So it's not just a discrete lesion which shouldn't be done. It's heavily calcified, it's got adverse outcomes on the table, it could have adverse outcomes while doing it, and it has adverse outcomes in the long run. So more the reason to avoid doing it, which therefore means how do you get your stents downstream, and that's the only reason why this lesion has been touched. And there are numerous methodologies, and I would have followed all those methodologies to get the stent downstream. The first question brings to my mind is there no way one can get a stent downstream to that discrete distal lesion? I know a long stent has been put, but in practical terms, I would feel that even a short stent could be put because there was only a focal area of stenosis which was demonstrated as clearly on IFR being significant, not a whole length of a lesion. And to treat that, one could actually get stents which go down, track better. There's the buddy wire which had actually been used. There could be a guide liner which could have actually crossed that proximal area to deliver a stent, and it would be a shorter stent which would be delivered for that discrete critical lesion before the bifurcation. Having done that, my job as far as this patient would have been completed. I would have left the mid lesion untouched. The moment we actually believe that we need to dilate a lesion for the sake of getting devices across, then we are committed to stenting it. And if it is a straightforward lesion, fine. But if we actually have a ugly lesion which has bad outcomes in the long term, it might be prudent, knowing that IFR was negative, to actually have left it and done it otherwise. That's what I would say. So my message is, get your best stent. It was a discrete lesion. I would have got a discrete stent out there prior to the bifurcation. And the lesion in the PDA, as you know, on IFR was not significant either. So there was only a single discrete lesion which needed to be treated. That's how I would have done it. I don't think I would have changed the prognosis of the patient in any way. Could have been similar if we take into account that we've had now 238 millimeter stents into him as well.
So Sayan is there, and I think he's done a lot of work on this, and I want his view on this. In a calcified lesion, which is distal, the biggest problem we face is the proximal part of that artery, which challenges us in getting the devices to that target. And inadvertently, we end up damaging it, touching it, or engaging those not so significant plaques. So how do you use IFR in tandem calcified lesions of this sort? Sayan, do you have a comment? I mean, you're still around?
Yeah, a very interesting discussion. What we've got here is information from physiology telling us where the problem is, but we've also got a problem with the mechanics of intervention. We have to get our equipment to the lesion, and all of the suggestions in terms of a guideline are all reasonable. This was particularly calcific and particularly tight, so I think you've got to take a pragmatic approach on how to treat the distal vessel. More often than not, I'll be honest with you, we don't have to treat the proximal vessel. This is just particularly tortuous.
Image.
I think 2 short stents may have tracked. That would have been an option.
Yes,
again, guideliner support may have been an option. But I don't disagree with treating the proximal just to get the mechanics of the intervention out.
Another point, short stent may not be an option. If you see the IFR points, it was 0.45 distally and 12 step up and 38 step up.
Yeah, but you remember that there was a wire whipping out there as well.
If you have treated only that the PDA, means the distal RCA lesion, your IFR would have become 0.85, not 0.9.
Yeah.
What you are aiming for 0.9. So you would have treated both the lesions.
You can put 2 short stents.
Yeah, two overlapping stents.
PDA and distal RCA.
Yes, that's right, 2 short stents. 12 millimeter stents would have done the job.
To get more than 0.9.
The issue, my issue is that's not the explanation for actually destroying the mid and proximal LED with a 38 millimeter stent.
No, I'm just talking about distal treatment.
Yeah,
with
so
RCA alone.
my issue is, in fact, that's the issue, not mine. That's that guy raised there. I wasn't even raising it.
I have this, Ajit, are you having difficulty putting that IVUS scan?
Yeah, it was going down, but I could get beyond the stent and take some pictures.
So-
It is just the bend, which is not
I
going
think
down.
this is the major reason that Ajit wanted to take a long stent down
Yeah.
first before
Yeah.
putting
Yeah.
a 38 millimeter long stent through the 38 millimeter long stent, because not only because of the calcium, because of the tortuosity distal to the stent part, it is difficult to take a device down. That is why probably he would have taken the first stent.
Yeah, I agree, Pratap. Once I decided to stent the proximal, the issue was short or long.
It didn't make a difference.
And if you saw the IVUS, yes, criticality of the disease was focal. But if you see the good to the good, it was pretty long, about 30 millimeters. So that's why I took the 38 and brought that down. And then once I get that, I agree with Pratap that that gives me a chance to at least get the IVUS up to the stented area. And you can see, despite putting a long stent and really bracing the RCA, the IVUS was not going down the bend. And that's because the stent now straightens the vessel. So let me just show you the IVUS. Sign? Yeah.
This is the IVUS with the stent implanted. So if you just go distal.
So if you can show the IVUS on the screen,
So
show
I
us
think,
the, can I,
is
yeah,
the
can you see
pullback.
the IVUS? Okay. So this is just distal to the stent. And now you can see the stented area, it's round, it's open, and as you pull it back, you can see that we are all right, and maybe that's the normal segment. There is some disease also there, and that's the guiding mark.
that's a great result, and I think very well demonstrated. Very well demonstrated. We've had great discussion, and I think Ajit, you at the end of the day could we also have some words from you and Christoph Owen himself, because we're going to go off air now.
Okay, thank you very much, Ashok, and for helping us together to host the first IPCI. By no doubt, this was a success because about the interest generated, and I thank all the delegates and faculty, especially the international faculty, to have come. I thank all my colleagues, Vijay Kumar, Sengutuvel, Dr. Matthew, and yourself, along with the co-directors who have put a tremendous effort in putting this meeting together. So thank you very much, and I will see you soon.
Thank you. Thank you. Great.